All right. Well, we will get started since we're after 12 o'clock noon. We have a really great session planned, and I'll let our two main speakers and main panelists today give a broader introduction for themselves. But we have Dr. Nancy Davidson and Dr. Tom Lynch, who are both joining us from the Fred Hutch and SCCA, and they're going to be talking to us today. They have an overview to talk about some of the upcoming challenges in cancer care and how our institution is going to be targeting some of those. And then we'll have a pretty larger set of time for some great question and answer, and we'd love to get some good discussion going. So as always, please feel free to put questions in the chat as we're going along, but I will turn it over to both of them to get started.
Great, Tess, thank you so much. And thank you everyone for coming to Medical Grand Rounds. So when Nancy and I were asked to do this, the concept that we had at the time, and we were kind of thought maybe we were being asked to do, is to talk a lot about the new plans to integrate the Fred Hutch and the SCCA and the University of Washington, and University of Washington medicine that focuses on cancer. And we realized that for Medical Grand Rounds, that's kind of boring and probably something you're not necessarily all that interested in. We'll talk a little bit about that. What we thought we'd do is, since most of the people who go to Medical Grand Rounds are medical house officers and medical students and people who are involved in the hospital care of patients in the medical service, what we thought we'd do is talk a little bit about some big trends in cancer and really do this as a discussion between Dr. Davidson and I and the audience to try to talk about what we see ahead in the world of cancer and make it more of a fireside chat type of format. So it's to be a little bit different. I'm not going to give you a 50-minute talk with 110 slides on the improvements in care of lung cancer. That would keep you engaged for about, you might go 6 minutes on that, but certainly no longer. I know Dr. Davidson could keep you engaged longer in breast cancer because the breakthroughs have been greater there. But again, we thought we would make this more of a fireside chat format. So what we'd like to do is start off by just giving you a little bit of background and information. So where are we now in cancer? So this is data as of January of this year. So more than 1.9 million new cases will be diagnosed in the United States in 2021, and that equates to 608,000 deaths, 608,570 deaths. The overall age-adjusted cancer death rate is 152 per 100,000, and that's actually down by 30% since 1991. Now, I was a second-year oncology fellow in 1991. So during the course of my career, it's come down by 29%. I happen to be somebody who studies and treats patients with lung cancer, and lung cancer accounts for about 22% of all cancer deaths. It remains the leading cause of cancer death in the United States. And notably, we still have room to move with cancer prevention and early detection, because at least 42% of newly diagnosed cancers in the US are potentially avoidable. So this gives you a sense of the two factors which have driven down cancer death in the United States. The first is cancer mortality. So the actual mortality from cancer, as I mentioned, has gone down by 27% over 20 years. Improved prevention approaches have reduced cancer incidence by 15% over those 20 years. And if you want to wonder what are those prevention approaches, most importantly, it's reduction of smoking. So smoking cessation, because smoking, as all of you know, is intimately involved in the development of lung cancer, bladder cancer, esophageal cancer, head and neck cancer, pancreas cancer, leukemia. So the fact that people are smoking less has led to a decrease in cancer incidence during that time. But it's not just cancer incidence that's down, it's also treatment that's had an effect. And Dr. Davidson is going to talk about breast cancer, which is one of the areas where I've been most gratified to see treatment advances making a big difference. Now, this takes a look at the cancers that have gone down in incidence, and you see several have gone down. The decrease in prostate cancer incidence, you should know, is probably a reflection in changes of screening for prostate cancer. Screening for prostate cancer still remains relatively controversial. and regional, depending upon where you are. There was a big enthusiasm for it in the late 90s, early 2000s, and it's a little bit less enthusiasm for it now. But you can see a steady decrease in lung cancer incidence, in colorectal cancer incidence, again, with better screening. And we know that Dr. Young's group and the GI group here at the University of Washington, I'm sure, loves doing screening for colorectal cancer, and it's made a huge difference in how we do. So screening has made a difference. But if you look at the 5-year survivals, you can see in certain areas, we actually are seeing improvements in 5-year survivals. So breast cancer 5-year survival is better, melanoma 5-year survival is better, prostate 5-year survival is better. But be careful, because those 5-year survival improvements could reflect stage migration and reflect the impact of finding cancers earlier. Okay, so it's not just, screening. The 5-year survivals might look better because we're seeing a different type of group of cancers. Probably the best evidence that we're improving, the treatment has made a difference, is a paper that came out in the New England Journal of Medicine last summer, from the National Cancer Institute, that looked at non-small cell lung cancer incidence and incidence-based mortality using a landmark analysis, and basically found that treatment improvements like EGFR treatment and now immunotherapy treatments are responsible for some of the decrease in overall death from lung cancer. And basically what the paper concluded, and it's true for non-small cell, it's not true for small cell. So we haven't seen the same decrease in treatment impact in small cell. In small cell, the decrease in death is entirely due to the fact that people are smoking less, not that the treatment has made any difference in small cell. And what you see when you look at the overall treatment and the overall mortality in non-small cell is coming down by about 2 to 3% per year. And then when EGFR treatments came out, it went down by 5 to 6% per year. And I suspect once we start to see the impact of immunotherapy and checkpoint inhibitors, we'll see it go down yet again. So treatment is making a difference in a disease like lung cancer. So I just want to give you a couple slides, 4 or 5 slides on cancer at University of Washington Medicine and the Fred Hutch. So the Fred Hutch was started in 1975 as a cancer research organization, did cancer research. In 1979, the first successful bone marrow transplant with an unrelated donor was done at the Fred Hutch. And this is the work that Dr. Thomas was awarded, Donald Thomas was awarded the Nobel Prize in 1994. And in 1994, the Fred Hutch moved to South Lake Union, and in 1998, the Seattle Cancer Care Alliance was started. Now, the Seattle Cancer Care Alliance is the campus here at South Lake Union, and there's not a ton of medical residents who rotate through the SCCA campus. Some, a lot of radiology residents and some surgical residents, and there are some medical residents, not as many as we'd like. Lots of oncology fellows, obviously hematology fellows who are at the SCCA campus. And the SCCA campus is here on the campus of the Fred Hutch. We share a campus, and it's the outpatient oncology services of the Fred Hutch, the Seattle Children's, and UW Medicine. And Seattle Children's has moved a lot of their outpatient oncology to their building care, which will be built over at in the campus of Seattle Children's. In other big things, we've had 3 Nobel Prizes that have been won at the Fred Hutch over the years. The Fred Hutch has also become a place that's done a lot in international cancer, with a partnership with the Uganda Cancer Institute starting in 2004. Also remarkable work in areas like immunotherapy and cancer prevention has happened here. In 2020, the Hutch was named the coordinating center for the COVID-19 prevention network. You might say, why would a cancer center be doing COVID? We got into COVID because back when bone marrow transplants were started, a lot of patients were dying from viral disease. CMV pneumonias and other type of viral diseases were quite significant. So Dr. Thomas felt it was very important to bring virology into the Hutch, and people like Larry Corey and Julie McElrath helped to establish a terrific presence in HIV. And so when COVID came around, we became a perfect place for working to develop vaccine trials in COVID. And you saw a lot of integration and tremendous collaboration between the University of Washington Medicine, between the Hutch, between Children's, in how we responded to COVID. And then in 2022, the new Fred Hutch Cancer Center will hopefully start. These are our plans. We're hoping that this will happen. We're waiting for state approval. So a couple of things about cancer cells and why are we so optimistic that we might be able to get somewhere in fighting cancer? And when I was talking to a group of students during the time that I was attending over at Harborview, talking to the medical students there, I was saying, I'm more optimistic now that we are going to cure cancer in the next 30 years than I was 30 years ago. And it really comes down to the fact that we have so many different avenues. We have much better understanding of cancer biology. Not perfect yet. It's not yet an engineering problem. We still need big investments in cancer biology. Prevention is incredibly important. Prevention beyond cigarette smoking. And Dr. Davidson can talk a little about that in breast cancer. Tumor vaccines have shown to be important. Genetic, epigenetic, and other omic profiling will play a large role. All of this will be enabled with great data science. Immunotherapy will continue to be important, and then cell and gene therapy is something that the Hutch has led in and will continue to lead in approaching cancer. We have 6 important priorities in terms of getting us to more cure at the Fred Hutch. And I think these are things that you can see in a lot of cancer centers around the country, but they're ones that we really believe in and make a big difference. And so when we break it down, precision medicine is the understanding of the genes, the proteins, the metabolic profile, the microbiome, all the things that drive an individual's cancer. And understanding what the cancer is and what the host is, and designing treatments specifically for that patient. Precision medicine, personalized medicine, molecular medicine, whatever you want to call it, that emphasis is going to be critical. Second, understanding viruses in the microbiome. We believe about 25% of all cancers are caused by viruses. We believe that even more cancers, work that Nina Salam is doing here at the Fred Hutch, suggests that even more cancers are caused by bacteria and parasites that we have that are present in our GI system and other areas. The concept of diversity, equity, inclusion as being absolutely critical, not just for the culture we have at the Fred Hutch, but also for curing cancer and for curing COVID. It's going to be critical for us to be able to make sure we understand why there's differences in outcomes, why a wealthy Black man has the same chance of survival from cancer as a poor white man. So we still have not understood the differences. It's not just access. It's access and other elements that we need to understand and need to interact and be able to make interventions that make a difference. The immune system will continue to be important. The Hutch has been a leader in the area of immuno-oncology. It will continue to be important in what we do. The intersection of tech, data, and science, none of this would be possible without what we have now in the cloud. We are in Seattle, the hub of tech innovation. So health tech, understanding big data sets, something that if you look at the work of Jay Shinduri at the University of Washington and Trevor Bedford at the University of Washington, the Fred Hutch, their work in virology and cancer, bringing all this data together, we're incredibly excited about it. And then prevention and early detection remains absolutely critical if we're going to make any kind of large scale progress. So the current state of this is the last slide I'm going to show, the current state of cancer care in the city: Seattle Children's, Fred Hutch, Seattle Cancer Care Alliance, University of Washington. If everything's approved by the regulators, what we hope we'll have is cancer research occurring at Children's, the Fred Hutch, and the University of Washington, and that oncology care will happen at these places as well. And so we look forward to working with all of you along the way to get us there. And I hope any of you in the internal medicine residency who aren't sure about what you want to do afterwards, you might be thinking about primary care, you might be thinking about a specialty, give cancer a serious, significant thought, because I will tell you, the advances that we expect over the next 30 years to be part of that, to be part of the molecular medicine revolution, to be able to improve outcomes, I can't think of anything more exciting to do. I know Barbara will tell you GI is the most important thing to do, and I'm sure the cardiologists feel the same way. But you won't regret going into oncology as a specialty. So thank you very much. And Nancy, I think you want to make some comments, and then we'll take some questions.
I do. Thank you so very much. I think, Lincoln, we could take down the slides if that's possible. Knowing that I was going to follow Dr. Lynch, who would be able to give this really wonderful introduction, I made the decision that I'm going to talk to you without any slides to amplify some of the comments that he made. So, in our field right now, we are celebrating, recognizing, if you will, the 50th anniversary of the National Cancer Act. It's worth pointing out that back in 1971, the president and Richard Nixon with the Congress came together and they passed and he signed the National Cancer Act. And so that we're spending a lot of time now thinking about where we've been, what lessons have been successful, and we're using that as a platform, of course, to think about the more important thing that Tom pointed out to you, which is where we're going. So I think that there are 4 crucial areas that we need to continue to focus on in cancer. And you've heard about all of them from Dr. Lynch, but I want to go back to them again. The first is that prevention and risk assessment, the importance of what we've already been able to achieve and where we need to go, cannot be underestimated. He pointed out to you some of the things that seem very easy, at least to say: tobacco avoidance. The obesity epidemic in our country. Obesity predisposes to a large number of cancers. That's going to turn out to be an issue that's going to be with us for the next several decades, and where we have to think about how we can help people with those lifestyle choices to avoid that particular risk factor for so many different kinds of cancers. But we're also at a point where we can think very, very concretely about risk assessment. Thanks to the amazing investments that have been made in basic science discovery, and which then led to clinical application, we can do pretty substantial risk assessment for certain people for certain kinds of cancers. For example, about the value of risk assessment for things like the genetic susceptibility genes BRCA1 and BRCA2 and the related DNA repair genes. And that if somebody looks like a suitable individual to be tested, we can identify someone who is what we would call a previvor, someone who has one of these abnormalities, and we can talk to him or her, because remember, these abnormalities predispose to breast cancer, to ovary cancer, to pancreatic cancer in some cases. So other than the traditional cancers that you think about, but we can talk to folks who have those abnormalities and begin to think with them about individualized screening strategies or potentially risk reduction strategies, which in many cases now take the form of surgery, but we'd like to hope in the future we'd be able to have a more medical approach. This is not only limited to breast cancer. Lots is known about colon cancer gene susceptibility now, and how one can try to identify individuals who are at higher risk, and how one might use that information to counsel them about better ways to think about their own colon cancer screening. And so we see that as being an increasing part of what we need to be able to perform, to be able to provide people with information about their personal susceptibility to malignancy, if and when we can also provide them information about what they can do to try to mitigate that risk. And I hope that we're going to see more of that. And that's not something that oncologists are going to be doing, right? This is something that we're going to be relying on all of us as physicians to be doing, just in the same way that you take charge of cardiovascular screening at the present time. Now, the second area has to do with screening and early diagnosis. Dr. Lynch pointed out to you that, first of all, this is a changing area. I think sometimes people are really frustrated that, the mammogram recommendations, a year ago they were this and now they're that. And I think that we should realize that one of the key things about oncology is the importance of clinical research. Basic research has certainly helped us to learn a lot about where we should go, but clinical research is pervasive in oncology. It is the lifeblood of everything that we do. And I think we're particularly proud as a discipline that we've been able to do clinical research in a way that provides fundamental, data-driven information to try to help our providers and our patients. So screening is a changing area. And that's why you do see changes in breast cancer screening guidelines, for example, as we refine our knowledge. That's why you've seen a change in the colon cancer screening guidelines just in the last couple of years to bring that down to the age of 45 because of information that we've been able to garner. That's why we have seen that evidence base that supports the use of lung cancer screening, something which we're really woeful at across the country, and where we ought to be thinking about how we can apply this in a more realistic way in order to try to provide early detection of lung cancer, because it will undoubtedly be associated with better prognosis. So this screening area is so important. A lot of it now is imaging or some kind of procedure, but the hope would be that there might be ways that we can be more precise and perhaps less invasive in the future in order to try to think about screening and early diagnosis. And for example, interest that's being addressed right now in the research realm about whether or not circulating markers might be a useful way of helping individuals to understand what their risk might be, and whether they perhaps have an early diagnosis of cancer that we should know about and we should be able to address more appropriately. So prevention and risk assessment, screening and early diagnosis. My third area is, of course, better treatment. And that's where so much of what I think you're exposed to as an internal medicine resident probably focuses on. I don't think we should forget, though, for a moment that although you're hearing from two medical oncologists today, that a lot of the great work that's gone on in this field has actually also been in surgery. You know, in my own world, when I started, if you had a newly diagnosed breast cancer, you would have a radical mastectomy. That means they would take the breast, the pec, the axillary contents, pretty big surgery. And thanks to our surgical oncology colleagues who have done a series of very, very methodical trials, and the women who participated with them, we've come to the point now where many women with early stage breast cancer are going to have a lumpectomy. They're going to have removal of only the sentinel lymph nodes, the ones that are likely to be the most informative. And they're going to have that associated with some kind of more limited radiotherapy than we used to do in the past. So enormous focus on local therapy that we shouldn't forget about: surgery, radiotherapy, interventional radiology, but also the thrust of a lot of what we've done, of course, is in systemic therapy. You know that we have available to us a lot of platforms: conventional chemotherapy, a lot of different kind of targeted agents, and increasingly the use of immunotherapy. And so much of the science over the last couple of decades has helped us to develop the places where we should use these therapies and to understand the subsetting of cancers in a way that helps us to pair these cancers with those most appropriate therapies. So for example, in breast cancer, there's several different forms of breast cancer: the hormone receptor positive one, the triple negative one, the HER2 positive one. And you know that we're going to use different types of therapies in those individuals, sometimes in the early stage in order to try to prevent metastatic disease, but of course, sometimes in the phase of metastatic disease as a way of trying to control disease and allow the patient and the disease to live harmoniously with each other. So prevention and risk assessment, screening and early diagnosis, treatment, and we can talk more about that in the questions. But I also want to put out that a really important thing for us to think about is the optimal use of what we already know. Some of our colleagues have estimated that if we could take our current knowledge base, our evidence-based guidelines, and provide them across the country evenly, that we would see a very substantial decrease in cancer mortality, and certainly in cancer morbidity, in a way that we don't appreciate now. Now, optimal use of what we know has so many different parts. One, of course, is we have to have patients come to the table. That we want to make sure that people present in an early fashion, that they have the appropriate screening that you and I have talked about, and that if they do that, that we intervene in the way that we should. So the second part is we as providers have to understand what the state of the knowledge is, and we have to be prepared to apply it. But of course, there's so many other aspects here. Some of them are practical. Policy, what things are covered, what things are not covered. Payers, what will payers pay for? Access to care, does everybody have equal access to these things? So these are extremely important challenges for us, because our ability to disseminate what we already know, that's ultimately what's going to have the most impact on how we do with cancer over the next decade and beyond. And that's where we're relying on all of you, because I think this is a common responsibility that we're all going to share. So with that, I think, Tess, if it's okay, Dr. King, we'll send the mic back to you, if you will, and allow you to moderate this so-called chat, which, as Tom Lynch said, we sure hope is going to include more than just him and me talking to each other.
That sounds great. Thank you so much to both of you for those really great introductions and just giving us a wonderful overview of, kind of where we've been as not just the University of Washington, but really as a society in caring for cancer. And hopefully we'll get a chance to have a bigger discussion now about where we're going. And just, I know we've probably had many people join us as you guys were starting to talk, but I encourage everyone to post questions in our chat. But just to start us off, you guys hinted at a really great collaboration between, University of Washington and Fred Hutch about some of the research going into COVID. And I think sort of always the elephant in the room is just trying to think about how how you all have seen the pandemic change and shape the cancer care that's being delivered, and maybe how it may, I think two-part question really. One is, how has it changed and shaped the way that we're able to deliver care now, and how do we see that evolving in the next several years?
Well, maybe I'll tackle that to start with, unless you.
No, I was going to say Nancy's.
Okay, yeah.
Nancy's the perfect person to talk about that because the SCCA has really led this.
Yeah, Tessa, I'd have to say that I am channeling so many people when I answer this question, because we will all recall that, we now know we're at the epicenter for COVID in the United States, right? The first cases were diagnosed and the first deaths took place in our state, and actually at the Evergreen Hospital, where some of our SCCA colleagues work. So we were all right there at the very beginning. And I think a couple of things were really key at the time and have continued to be key going forward. That first is what we just talked about, awareness, making sure that people know what's going on. So dissemination of information rapidly and hopefully accurate information. The second is that in the oncology space, we were actually particularly fortunate in the sense that, we are already very, very focused on infection, right? Infection control, infection prevention. That's a key part of what we do in oncology. And so many of the methodologies that we already use could be maintained and brought to bear in the setting of COVID when we were trying to figure out what's going on. I think a third thing that we all did, of course, was to think about what's urgent and what could be slightly postponed. Now, in cancer, of course, you might say to yourself that at the beginning that everything is urgent. But in fact, some things are more urgent than others. There are some cancers that are slower growing than others. And so, for example, in our breast cancer space, we made the decision that older women with a mammographically detected hormone receptor positive breast cancer could safely be treated with hormone therapy at home, an oral hormone therapy for a few months, to allow them to stay away from the hospital environment, to be getting appropriate treatment for their cancer, and then to allow us also to make sure that we were pivoting those critical acute care resources like the operating rooms to those who might need it. Now that's a really major change that we've been able to continue to capitalize on as we've needed to. And the last, of course, is certainly not specific to cancer. Everybody on this Zoom knows that 2 years ago, you were almost certainly not a practitioner of telehealth. Everybody on this Zoom today is an experienced practitioner of telehealth. And so I think one of the other things that we came to realize that there's a lot, even in acute cancer care, that we can do outside of the medical space in order to try to make sure that patients stay safe, get the therapy that they need, and be tied to the system as they need to do it. So all of those things I think have been so important to us.
I'll give you one example also that I'd like to hear Dr. Davidson's perspective on, something that's similar between COVID and cancer. Last week, we saw the exciting data on molnupiravir that came out, the Merck data that looked really exciting. And that was done, some of that work was done at the outpatient COVID research center here at the Hutch. And at the same time, a study was done here using remdesivir, again, early in the course. And, one of the things that we find is that early antiviral therapy likely is going to be much more effective than later antiviral therapy. And as one thing I've always thought about is the similarity between in Nancy's career, one of her greatest accomplishments has been actually increasing the cure rate of women with early lung cancer by applying things that we learned in advanced lung cancer. So we first saw remdesivir worked in intubated patients in the ICU, and now we know it works best if you take it right after you find out you have COVID. And Nancy, you've done a lot of work in breast cancer where that paradigm of taking something that might work in advanced disease, bringing it to early disease and increasing the cure rate must be one of the most gratifying things you've seen.
I think you're absolutely right, Tom, that this has been true in breast cancer. It's true in some other kinds of cancers. It's not completely concrete, but I think you're right that one of the models across many types of solid cancers, and breast cancer is one of the poster children for this, is the notion that understanding a new therapy, a new systemic therapy in the setting of advanced cancer, and that means showing that there's improvement in tumor and that it's well tolerated, because there's two parts here, right? There's both efficacy and there's toxicity. That therapies that work in that setting of advanced breast cancer frequently can be promoted and used in earlier stages of breast cancer. a seemingly curable breast cancer where we know from the vast information we have from clinical trials that there's still a finite chance of metastasis at a later date, which is presumably because of micrometastasis at the time of diagnosis that could not be detected. Our studies just aren't good enough for that. So we try to use information that we can get from the cancer and the host these days to get a sense of how likely it is that that micrometastatic disease exists, and then think about these therapies that have been credentialed, if you will, in advanced breast cancer, and whether if you bring them forward into earlier stages of breast cancer, you would be able to prevent that recurrence in the first place. This has worked beautifully in hormone therapy. So I think that this is a great area. It's been, in the last 20 years in the HER2 breast cancer space, the subset of breast cancers that make the HER2 protein and are very reliant on that signaling pathway. Those breast cancers have turned out to have wonderful opportunities for treatment in metastatic disease. And we've been able to bring it forward and change the life expectancy for women with early HER2 positive breast cancer. Even my relatively short career, that was a sort of a death sentence for women some decades ago. And these days we think of HER2 breast cancer as one that is pretty controllable, one that we think we have a lot of opportunities. So these models are very important. Also speaks to the clinical trials, Tom, that sometimes what we do for clinical trials now with that thing that looks like it's pretty effective in advanced cancer is to bring it forward into what we call neoadjuvant or preoperative trials. That is to give the systemic therapy first. So you can, first of all, hopefully make the job easier for the surgeon and the patient, but also so you can get some kind of response in that patient, some sense of whether the therapy is effective or not. And that also can be extremely useful in the drug development area. Tom, I think that in the pharma industry where you spent some time, and in the FDA, the regulators who think about these things, that's a model that people are paying a lot of attention to now, because it allows you to kind of call through the many, many opportunities we have to try to focus on those that are going to be the most rewarding for patients.
That's great. Thank you so much for both of you guys for commentating on that. Another question we've had that's come in is just thinking about, and I think that some of this is relevant to the increase in cases maybe that we've been starting to see as people are getting plugged back into care after the early parts of the pandemic. But we are seeing an increased rate of advanced cases of cancer at younger ages, and just a question about any of your speculations as to why that might be, or what some of the major contributors are to that.
So I think Dr. Davidson talked earlier about how we're definitely seeing more young cases of colorectal cancer, and that has led to a understanding that the age of screening likely should be moved up for everyone and for patients with families that have high risk. And so we're seeing seeing greater numbers of cancer there. I don't want people to think there's been a massive pandemic of early cancer, of advanced cancers in young people, knowing that most of the house officers and medical students are young people. So not all, but most. And it's still, cancer still remains a disease of aging. And I think that's an important thing to keep driving home, is that, when we talked about that improvement in overall cancer, the actual number of people each year in America who die from cancer continues to go up. It's the relative reduction because that's the aging of the population. Okay. And so the reason we think we've made progress isn't because we've reduced the number of Americans dying of cancer, but because of the age-adjusted death rate is going down. The population is still an older population in America than it was 20 years ago in terms of our demographics. But I do think that this emphasis on screening and prevention are incredibly important, and they're hard to get people to do. Right now, McGarry Houghton, who's one of our pulmonologists at the University of Washington at the Hutch, yesterday shared data that said 4% of eligible people are screened for lung cancer. 4% receive CT scan screening for lung cancer. How many of the house officers on this call in their clinic population that they see in their outpatient population order screening CTs for people with 20-pack year smoking histories over the age of 40? Very few. Okay, maybe at UW it's perfect, but everywhere else it's only 4%. And how do we increase that acceptance? Another thing, we have good evidence that a drug like tamoxifen can prevent cancers, breast cancers in women. And Nancy, how many women are actually taking tamoxifen who are at risk for it? And we have good evidence that you can reduce your risk of getting breast cancer.
Same thing, less than 5%. And, you know, there's a lot of question about why is that? And I think part of it is the sense of it's a cancer drug. Okay. But, you know, it's a pretty good drug. It's a drug that's probably the most studied in the world, practically. It's certainly been used by millions and millions and millions of people. But we know that you're right, Tom, that sometimes these prevention strategies are difficult for people to grasp. First, because they don't really think they're at risk, right? None of us really thinks we're at risk. And second, because they usually require adherence, which is a really important part of, you know, that's been very interesting for us in the cancer field. Because remember that for medical oncologists, our field for a long time was about giving IV drugs and managing toxicity, right? Our mantra was, we're going to give a lot of it and we're going to get you through. And if we've given you a lot of it, you're going to do better. And of course, what we've come to realize is that more is better, maximally tolerated dose is not really the right model right now. It actually is more what we would call the minimally effective dose, right? We want to pick out the dose that is the smallest possible to give you the biologically important endpoint that you need to see. But that also means that for some of these things, it's going to be a chronic therapy. And that's where we, who are used to giving IV treatment for acute periods of time, are needing to learn from the rest of our internal medicine colleagues, our cardiology colleagues, our diabetes colleagues, about how it is that you enable and encourage individuals to, first of all, think about their risk of developing cancer, never very happy for people. And second, think about some of these things that might be chronic interventions, either prescriptive, right, things that you take, or in some cases, lifestyle changes, which also need to be maintained over a matter of time. So huge area for us as we try to think about how to pivot the way we think about things as oncologists, because I think increasingly we want to be in this space that's not just when the diagnosis is made. We want to be in this space that allows us to, in some cases, make sure that you never get that diagnosis of cancer.
So along those tests, if you don't mind me asking, there's a question that came in that I think would be really interesting from Vicky, which asks us to comment on the blood tests such as GRAIL. And as many people may know, there are companies like GRAIL and other companies that have developed early molecular tests that can take blood and look for clonal evidence of oncogene activation in peripheral blood. Now, remember, we all have evidence of clonal hematopoiesis. That's not what it's looking for. It's really looking for certain mutations, patterns of mutations, and it's really been something which is terrific for finding advanced cancers. You can, one day we might even find that liquid biopsies become, even more important in being able to diagnose cancer without having to do an invasive biopsy. We may be able to do it off of a blood test. In many parts of the world, for example, in lung cancer, a simple EGFR mutation test from the blood diagnoses the lung cancer. You don't need to do a lung biopsy. However, in most places, we're still doing biopsies. But this idea of early detection is incredibly exciting. However, it's still not proven. And Nancy, the SCCA is doing some important work with Amazon and GRAIL to try to look at that and try to come up with an understanding of when should these tests, because the answer to the question that Vicky Fang asked, I don't know whether you should get that test or not. It's a powerful test, but we don't know if it's useful.
Tom, you raised a good point. Actually, Vicky, I think, was one of the people who might have been involved with us. We did have a really nice conversation with Amazon for quite some time about the possibility of helping them in this space. And I think as a company, they've decided that maybe the technology is not quite ready for prime time in the kind of early diagnostic space. But I think we should stay tuned, because there's no question that these tests are out there. And we're the ones that have to think a little bit about how we're going to use them effectively. How do they help us do what we need to do? And also to address the question that was asked about, well, this is great, but if you have it, and if it's for the worried wealthy, does this really help us in terms of where we all need to go? I want to take that and actually go to another question from, I think, David, who talked about, as an internist and a health economist, he's really worrying about the proliferation of high-cost, marginally more effective cancer therapy and the inequality that we see around the globe. Well, David, first of all, I agree with you on that. And I worry about actually in this country. I think that, not to say that we're perfect by any means. I would point out to you, just in my little field, remember I mentioned to you anti-HER2 therapy. Early use of the drug called trastuzumab or Herceptin is part of the mainstream, the recommended therapy for early stage breast cancer. Our colleagues in North Carolina, who have a very, very robust state health system or state records where they can look at this, what they found was that the likelihood that Black women with the same kind of HER2 breast cancer would get HER2 therapy was lower than white women. And you and I can think about a million ways why that might be the case, but that's not good. This is a proven therapy, paid for by our insurance every which way you can. Toxicity well described, 1 year of therapy pretty defined, and how can we not be providing access to that therapy to every single woman or man who would have the appropriate kind of breast cancer? On the international scale, this is even more important. First, we're all aware of the fact that there are many countries actually will have national groups that look at this. In the UK, the NICE system, the NICE group, looks and stratifies therapies, and they decide which ones are appropriate for them to cover in their health system and which ones are not. And so I think one could think about that kind of strategy. Not very, very popular in this country, and certainly not something that we've been prepared to take on just yet. I also think that folks are looking at this. Ben Anderson, our colleague, our surgical colleague from the University of Washington, has actually left us for a couple of years, and he's working with the WHO, and his interest is in breast care and how you can provide the best possible breast care and therefore breast cancer care across the globe. So he's been thinking a lot about stratification. How can you think about what we know about treatment of breast cancer and bring it to bear in the ways that are appropriate for low-income countries, for middle-income countries, and for high-income countries? And of course, the goal would be to pick out the core things that should be done everywhere, and then to think about how countries can gradually come up that pillar. So people like Ben have been thinking deeply about this, and there's a wealth of literature now, and something that the reason why he's at the WHO is try to think about how to do this, because breast cancer actually turns out to be the most common cancer in the world right now. It surpassed some of the other cancers not too long ago.
And Nancy, one of the things that struck me was we had a visiting scientist, a visiting surgeon from Lucknow, India, visit at Yale when I was the cancer center director. And she brought an iPad with her slide deck of what breast cancer looks like in Lucknow, India. And oh my gosh, is it a different disease?
I think you're right that it is not strictly access to care always that dictates some of these things. There's no question that it's extremely important, but there are biological differences with a lot of these cancers that we're still trying to unravel, even despite all the inroads we've been able to make because of things like the TCGA, the big sequencing, the big profiling effort that we all paid for as taxpayers, that the National Cancer Institute undertook over these last 50 years to really, provide the molecular profiling of a lot of the common and uncommon cancers so that we could understand the pathways that seem to be involved. And so we could use that to our advantage to think about, again, early detection, interception, how you might, interfere with the carcinogenic process, and how you might use that knowledge to think about the development of targeted therapies.
And David, one more thing to answer to your question, just to let you know, one of the things we're doing at the Hutch, we have a trial that we're doing in Uganda of a depot injection of Rituxan, which is a really important drug in treating lymphomas, a monoclonal antibody. And we give Rituxan to patients with lymphoma to see if it can be done in a low resource environment, because the problem you have is Rituxan in the United States is given with an infusion in an infusion center like we've set up at the SCCA and around other parts of the country. And it's something that we're good at doing and can do safely. Infusion centers are not practical in most parts of the world once you're out of Western Europe and the wealthy parts of Asia and the US. And so if you had a drug, a monoclonal antibody you could give by depot IM injection that could have the same benefits, and lymphoma is a huge issue in Uganda. And so the odds of the hope that we're going to be able to impact lymphoma therapy there with a formulation of the drug that can be given in low resource settings is something we're working toward. It's been a very hard study to do. Doing clinical research in Africa is for this disease is challenging. Our HIV group has done, and our COVID group has done wonderfully, particularly in South Africa, in terms of accruing to trials. We've struggled more in Uganda with this approach.
I think the question about equity, certainly in the international space is a huge one. And I appreciate you guys giving insight into that. And I think it kind of dovetails nicely into another question we received. Really, and Dr. Davidson, you had hinted at this earlier in your answer, but kind of bringing the equity issue a little closer to home in a more regional sense. When, certainly when we think about the cost of drugs and cost of care delivery, that's a huge issue in the space of healthcare equity within cancer care. But, thinking more broadly about, the access to prevention, getting patients into prevention or into screening, I should say, through their treatment. And then even now, as we've had this rise in, or I guess decrease in mortality, the increase in cancer survivors and keeping those patients plugged into care and adhering to care like you were talking about, what are some of the things that you all are aware of or that are kind of happening within the UW and within the Fred Hutch space that's working towards equity across this kind of whole spectrum of cancer care, just in a more like local sense?
Well, I think this is a major thrust of our Comprehensive Cancer Center, which Dr. Lynch leads. So all parties are responsible for this. And I think it really spans the spectrum. Tess, one thing we're doing, for example, is we all have come to realize that we cannot expect that all patients are going to drop everything and come to our big centers, right? So one thing you could do is to start to disseminate care out into the community. That's why we have our neighborhood clinics, where we're hoping that a lot of the cancer prevention and screening is being undertaken. And we're certainly trying to do the same thing in the treatment space. The SCCA over the last decade has put in place 5 different centers across the Puget Sound region so that our patients can safely get the same kind of care, by and large, that they would get in South Lake Union or at Montlake if they're cared for with our group at Overlake, at Evergreen, out on the peninsula in Issaquah. Of course, now Northwest, we are all one big family. So that's one way to do it, is to bring it closer, particularly when much of cancer care, as we've just talked about, is increasingly chronic. You can come to the center if you need to have something done, but if it's something that's going to be across your daily life, if it has to be integrated into your daily life, then I think having it closer to home is extremely important. The corollary of that, though, is if something comes up, if you develop acute leukemia, you probably want to be in the mothership, right? And so that's part of what we need to do in order to make sure people get the best possible care, is if you have one of those illnesses, which is best cared for in a center like ours, with all the bells and whistles, all the multidisciplinary specialists wrapped around you, a complicated sarcoma, pancreatic cancer, acute leukemia, the need for a bone marrow transplant or a stem cell or CAR T therapy. I think those are the kinds of things where we want to make sure that people know, the providers know, that this is an appropriate treatment, and that those patients have the opportunity to come to a center like ours to receive that high-tech therapy for those relatively rare circumstances. So for me, it's partly making sure that we have capabilities in a lot of places for the more common cancers, if you will, but that we also have the capabilities that are required for those that have perhaps the rare presentations of those common tumors or the very uncommon tumors. Huge for us. A lot of places, Tom, did you want to say something?
No, keep going.
I was going to say, I think the other parts of it, certainly have to do with, we're relying on you, right? We need you. I'm looking at all of you in the audience. You're the folks that have to help us with the screening.
Yeah.
You're the folks that really have to help us with trying to help people to understand their risk. There are simple models that are available to calculate one's breast cancer risk. And it's a rare internist or family practitioner, in my experience, and I say this as a patient in addition to a provider, who does that with a woman, right? And yet we know, as we heard, there are FDA-approved interventions that could be considered. And so, it's incumbent on us in part to make sure that we take the knowledge that we have and democratize it, that we get it out to everybody, and that we use that information to help them to make the decisions that are the most appropriate for them.
And I wanted to add something almost exactly what Nancy just said, but with maybe a little twist, which is one of the things I'm so excited about with the integration and creation of the new Fred Hutch Cancer Center, is we're going to have the cancer services of UW Medicine as part of this. It's not just that the SCCA and the Fred Hutch are coming together. It's the cancer at UW Medicine is going to be part of the Fred Hutch as well. And we're going to be working together in this area. And if you think about it, if you want to look at impacting cancer screening and the question that Vicky Fang had about GRAIL and questions of other forms of early detection and screening for lung cancer and other things, that doesn't happen in a cancer center. That happens at UW Medicine in Issaquah. That happens in UW Medicine in Southern King County and in Mukilteo. So, it's really important that we broaden the definition of what cancer care is and where it's done. It's something that's got to be owned by internal medicine as much as by oncology. And the second thing, just to talk a little bit about local disparities, and Dr. Davidson mentioned how important our Cancer Center Comprehensive Cancer Center grant is, which is a grant awarded to the Hutch, University of Washington, and Seattle Children's, is that we are responsible for assessing the needs and care of our catchment area and our state. And so, for example, Jay Mendoza's team, who runs our community outreach and engagement, we have a whole effort looking at the Yakima Valley to see, can we put healthcare navigators in the Yakima Valley to reach Hispanic populations there that may not have access to cancer care? How do we look at Monday is Indigenous Peoples Day in the state of Washington. How do we look at the fact that there are big differences in outcomes for Indigenous people who develop cancer than there are for Caucasian people who develop cancer? And so, again, the kinds of things that we have to address both from a research standpoint, but from a care standpoint as well.
And Tess, if I could add, because this, I think, speaks to somebody like you. Thankfully, we have ever more cancer survivors. And cancer survivors, unfortunately, are still people who are a little bit more at risk for other kinds of cancers. So secondary cancers related to their underlying condition or perhaps the treatment they got. And increasingly, those folks have got to be coming back to internists like you, right? That's where they're going to be getting their holistic medical care, because cancer may not be the most important thing on their radar anymore, but we need to make sure we're looking after their cardiovascular risk. So I think we're also relying on our internal medicine colleagues to help us with the survivorship part of this. Because again, in my little field, early stage breast cancer, most women are going to survive that early stage breast cancer. They're going to go on to become ill from and die of other things. And so I want to make sure that you are helping them to think about the totality of their health as they go forward in those decades ahead. And increasingly, we hope we're going to see that with other cancer types as well.
Or men with prostate cancer or androgen deprivation therapy who develop horribly increased rates of diabetes, coronary disease, stroke. These all become things where working with the internal medicine community is going to be important. But I would be remiss to say, maybe at UW Medicine it works better. At the other places I've been, which are pretty much MGH and Yale, there's always a little bit of tension between the oncologists and the internists in terms of where those boundaries are and how we can work to make them better. And one of the things that Paul Ramsey and I are working on is to try to think about how can UW Medicine be better integrated with the cancer effort at the Hutch. And I think it's something that we think is going to be critical.
Yeah, thank you so much for all of that. And I love the thought and discussion about the survivorship piece. I think it's really especially important, as you guys have mentioned, there's so much overlap with how general internists are really key members in playing a role across the cancer care spectrum. And I think, since this is an institution that has so many different types of trainees, how do you envision, or how do you see some paths towards helping develop and expand the exposure and training so that people who are, not just in the hematology and oncology fellowship, but people kind of across different levels of training are able to get the right exposure and ability to really intervene in these ways that you all are talking about?
Well, first, I think it's going to be an ongoing process, right? I think that all of us have come to realize that you're not going to get everything you need to know in medicine during your training, and then that's it for the foreseeable future. The second, though, is I hope that we're speaking to the people who are involved in those curricula. I'm obviously extremely biased, but I think that the exposure that internal medicine residents get to cancer is relatively limited. And it frequently is on the inpatient service, where there's important work to be gained, education to be gained about some of the management of acute malignancies and the complications from therapy and malignancies. But I'd like to think that there'd be more of an attention to the outpatient part of oncology, Now I realize there are so many competing priorities, to try to assemble or to train a well-trained internist going forward. But, I think it would be wonderful if we could think about a little bit more of an outpatient exposure, because you would be able to see some of the issues, and then you would be able to think about how you're going to be embracing them and trying to tackle them going forward.
And I don't want to seem negative, but I have struggled in my career with trying to design better outpatient resident experiences in cancer, because medical student outpatient experience in cancer is fantastic, because medical students love basically following a doc or a fellow in the clinic. It's great. Shadowing is a great thing for a medical student. Medical resident has zero interest in shadowing. And yet a medical resident has zero ability to actually provide the care. So they're in that, whereas the fellows are in a position where they can provide care, supervised care. How do we find ways to have residents provide supervised care? And this is a struggle that we all have had across a number of different places. And I don't think we fixed it yet, because the experience in oncology in the inpatient service is, I won't say it's irrelevant, but it has almost nothing to do with what an oncologist does every day. It's a completely different world than what we see inpatient. So it's something that we got to figure out, because I think for all the reasons we talked about in this talk, it's going to be important.
This is great. Well, I want to be respectful of everyone's time and just acknowledge it's about 1 o'clock right now. And I know we've had many questions come in, and I think we've hopefully gotten to a number of them, and apologies for those that we did not get a chance to cover, but this is obviously a broad topic, lots to discuss, but thank you so much for both of your time, and for everyone who's been attending with us too, and listening and submitting questions. Thank you for making this a really diverse and wide-ranging discussion.
Thanks, Dr. King, for hosting us. We really appreciate the chance to come and talk.
Thanks, Dr. King.
Yes, absolutely. Have a wonderful afternoon and rest of your weekend, everybody. Thank you.
Thank you.
Bye.